All right, let's get right into it. Welcome, everyone. Today's explainer is basically your ultimate high-yield board review ward round. We're tackling intra-abdominal infections and abscesses. Look, if you're gearing up for medical board exams, you already know this topic is an absolute goldmine for test writers, right? So we're going to strip away all the fluff, focus on exactly how these concepts show up on test day, and give you the mental frameworks you need to really lock this stuff in. Okay, here's our roadmap for today. We'll hit pathogenesis, classify peritonitis, do a deep dive into SBP, tackle the high-yield micro, and wrap up with abscesses and clinical syndromes. Let's dive in.
Starting right off with stage 1 and 2, the pathogenesis. So understanding the temporal shift in these infections is absolutely crucial. It's the foundational key to mastering treatment questions. Imagine a perforated appendix, okay? Stage 1 is the immediate aftermath, peritonitis. This early phase is super dangerous, life-threatening, and it's completely dominated by aerobic gram-negative organisms, especially E. coli. This is the stuff that drives early bacteremia and sepsis. But let's say a patient survives this initial peritonitis phase. Well, the environment inside the abdomen actually changes. We enter stage 2, which is abscess formation. And, this late stage, it is totally dominated by anaerobes. The infection walls itself off and basically creates a permanent reservoir for bacteria. So remember this 1-2 punch, early gram-negative sepsis followed by late anaerobic abscesses.
Moving on to classifying peritonitis.
Distinguishing between these types is a massive, frequent exam trap. There are 4 major categories you need to be able to identify rapid fire. First is primary, or spontaneous bacterial peritonitis. We'll get into that in a second. Second is secondary peritonitis. Think of a hollow viscous perforation, like a ruptured ulcer. Third is tertiary peritonitis. Test writers love this for the ICU setting. It's usually a patient with recurrent peritonitis despite getting treated, and it almost always involves multi-drug-resistant bugs like Candida, Enterococcus, or Pseudomonas. And finally, tuberculous peritonitis. Your buzzwords here are a subacute presentation, exudative ascites with lymphocytic predominance, low glucose, and crucially, a high ADA or adenosine deaminase level. Now, pay close attention here because this is the ultimate board battle, primary versus secondary peritonitis. Primary SBP is almost always monomicrobial. There's no surgical source to fix, right? So you treat it medically with antibiotics like cefotaxime and IV albumin. Secondary peritonitis, on the other hand, is polymicrobial. Why? Because a hole in the gut just spilled a massive mix of bowel flora into the abdomen. It absolutely requires surgical source control. So if a question gives you an acidic fluid culture that grows multiple organisms, alarm bells should be ringing. Suspect secondary peritonitis immediately and pick the surgical consultation answer.
Next up, our deep dive into spontaneous bacterial peritonitis.
This is arguably the single most heavily tested condition we're covering today. Memorize this number, 250. If you do a diagnostic paracentesis and the PMNs, the polymorphonuclear cells, are greater than or equal to 250 cells per microliter, that is it. That's your absolute diagnostic threshold for SBP. You do not sit around waiting for fluid cultures to come back. You see 250, you start empiric antibiotics immediately. Let's test this with a classic high-yield board scenario. You've got a cirrhotic patient, their PMNs are over 250, and you're starting an antibiotic like cefotaxime. What other landmark intervention do you absolutely have to give to dramatically reduce the risk of hepatorenal syndrome and overall mortality? Think about it for a second.
The answer is IV albumin. I can't stress this enough. This is a massive score-saving exam pearl. Giving IV albumin, specifically 1.5 grams per kilo on day 1 and 1 gram per kilo on day 3, alongside those antibiotics, is a landmark intervention. It literally pulls fluid back into the intravascular space, supports renal perfusion, and stops that dreaded hepatorenal syndrome in its tracks. Seriously, never forget the albumin.
And while we're on the topic of important numbers, here's another one, 1.1. When you're evaluating ascites, you always calculate the SAG, the serum ascites albumin gradient. A SAG of greater than or equal to 1.1 indicates that portal hypertension is what's driving the ascites, and that is the exact setup you need for SBP. An easy way to remember this? High SAG means high pressure. If the SAG is less than 1.1, that points you away from cirrhosis and towards something exudative, like malignancy or TB.
All right, let's pivot to high-yield microbiology, specifically Bacteroides fragilis.
So get this. One specific bug completely dominates the lower gut.
The ratio of obligate anaerobes to aerobes in the distal small bowel and colon is a staggering 1,000 to 1. Just massive. And the absolute undisputed king of those anaerobes? Bacteroides fragilis. This crazy ratio is exactly why B. fragilis is the most important anaerobe you need to know for these intra-abdominal infections.
So why do the test writers obsess over B. fragilis? It basically comes down to two major virulence factors. First, it has the sneaky polysaccharide capsule that prevents phagocytosis and actively promotes abscess formation. It's an abscess factory. Second, it produces beta-lactamase. That means it is constitutively resistant to penicillin and ampicillin. They won't even touch it. If you're treating an intra-abdominal infection, you have to deliberately pick an antibiotic that covers B. fragilis. We're talking metronidazole, piptazo, or carbapenem.
Moving into our final stretch, abscesses and syndromes. We need to nail down the management of localized infections. Burn this golden rule into your brain. For intra-abdominal abscesses, source control is mandatory. Antibiotics alone are completely insufficient for a cure. You can pop a patient full of the strongest, broadest spectrum antibiotics on earth, but if there's a walled-off collection of pus, they are not getting better. It has to be drained. Never, ever choose an antibiotics-only answer for a confirmed abscess.
So how exactly do we get that source control? Well, for the vast majority of accessible, unilocular abscesses, like a single hepatic or paracolic abscess, CT-guided percutaneous drainage is your absolute first-line therapy. It's minimally invasive and works great. But surgery becomes your necessary fallback if that percutaneous drainage fails, if there are multiple loculations making a single drain useless, if the abscess is hiding somewhere inaccessible, or if the patient is showing signs of diffuse peritonitis.
Let's do a quick rapid fire of classic biliary syndromes that tie into all this sepsis stuff. First is Charcot's triad: right upper quadrant pain, fever, and jaundice. When you see these three together, it points straight to ascending cholangitis, a pyogenic infection of the biliary tree. This patient needs IV antibiotics covering gut flora immediately, plus an urgent ERCP to decompress that biliary system. Now, what if things go sideways? Take Charcot's triad, add in hypotension and mental status changes, and boom, you've got Reynolds' pentad. This means that ascending cholangitis has progressed into severe systemic septic shock. This is a dire, life-threatening medical emergency requiring immediate intervention.
To wrap up today's explainer, I want to leave you with a scenario that really tests how well you've integrated all this. Imagine your patient's acidic fluid shows PMNs over 250. Okay, you're thinking SBP, right? But then, the culture comes back showing E. coli, bacteroids, and enterococcus. It's polymicrobial. So what's your move? Are you dealing with SBP or a surgical emergency? Based on everything we just talked about, you know multiple organisms means secondary peritonitis. The gut has a hole in it. It is absolutely a surgical emergency. Keep these key distinctions sharp. Trust the frameworks we just built, and you're going to crush these questions on test day. Thanks for hanging out with me on this high-yield explainer, and keep studying hard.